Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. We're going to have a great OCT investigative and analytic workshop and lecture with Dr. Diana Shechtman, who was a full-time professor for 18 years at Nova Southeastern University, where she served as a coordinator of the Diabetes and Macular Clinic and the director of interdisciplinary education program. Wow, that was so long ago, Diane, that you and I were both there. It seems like a lifetime ago.
It does. It does.
She is an active board member for Women in Eye Care and Latino in Optometry. She's also an active member of numerous professional committees, including the Broward County Optometric Association, and has been named Newsweek one of the best eye doctors in the U.S., and she's currently a consultative optometrist at Low Ophthalmology and Associates, as well as a retina consultant of Miami. So I'd like to have a nice virtual warm welcome for our friend and colleague, Dr. Diana Shechtman. Diana, take it away.
Thank you, guys. Thank you so much. And it is truly an honor and a pleasure to be here with both of you. Let's get started on the OCT. These are just my colleagues that I have the pleasure of working with. And many of these cases are going to encompass, I have no financial disclosures, but many of these cases are going to encompass cases that would not only deal with retina, but we're going to deal with glaucoma, some optic neuropathies, and some obvious and not so obvious cases. But here's my first poll question, because I'm always intrigued to see what the audience is and who we're dealing with. Do you have an OCT in your office? Just simple yes, no, or perhaps no, but I am planning to get it maybe a Christmas gift for 2025 or into the new year.
So Diana, just so you know, I added a little secondary question to it. If they have an OCT, I was wondering if they had OCT angiography, and OCT anterior segment. So I added a little twist to your first question.
I like it.
Polls are rolling in nicely here. Give it a second or two. Obviously, I don't think there's going to be any questions in the chat box yet, are there, Joe?
No, but you'd be surprised, Greg. Sometimes I get a series of questions before the lecture even starts. Just not tonight.
Okay. All right, Diana. So here's your audience tonight. Your audience is 73% with a yes, with a 20, well, to just drop the, 22% with a no. And we have a 6% that are saying, we're planning on getting one here in the near future. So say 75-25 with a 5% getting one in the near future. And I'll close that poll and display. We have an audience that has OCT 55%, then adding on OCT angiography 12%, and then anterior segment 33%. So there's your audience with your OCTs, OCT angiography, and anterior segment.
It is remarkable to see that. I mean, I remember doing lectures where you had a large audience at the American Academy of Optometry. You maybe had 5 hands raised. And nowadays, we have such a large percentage of individuals who are using numerous diagnostic modalities, including OCT as well as OCTA. Let's start with interpretation. This is a case that I actually saw, I would say about a month ago, I think now. And I'm going to start and end with this case because I actually found this case to be really interesting, and it wraps everything up into one. So I will not going to give you the final answer. I'm just going to be, it's what I would call a teaser, and seeing the fact that my new love has become Pilates, teasers, it's all what I'm about. Blurred vision occurred about 2 weeks ago. Now, what had happened was that during that blur out of the vision, which lasted, he said, several minutes, he did say that it did recover, but just that eye doesn't seem right. He had seen his PCP, who was the individual who referred him to us, has had a family history of glaucoma, and all this is going to become important. Visual acuity was a perfect 20/20 in both eyes. Pupils, EOMs, confrontation fields were unremarkable. There was no cataracts, no other changes at hand, and the pressure was just slightly high at 20 and 22. Now, again, I just want everybody to take this in and seeing if you would have been able to identify at least the abnormalities shown here. Without question, the images on the side is a Heidelberg There is definitely glaucomatous findings of a nerve fiber layer defect. Having that with the cupping, which is not a perfect picture right now, but that family history, increased IOP, even without the fields and the pats, pretty much puts him at a high risk for glaucoma. But this is not a case where he snuffed his last nerve fiber layer. Is there something going on in the macula? How would you manage this? So I just want you to think about this. I just want you to really just take a look at it. And towards the end, we're going to tie everything up and give you a final answer for this particular case. So interpretation number 2, seeing things a little bit subtle. Are there any differences between them? When presenting these two cases, these are two of my cases, you see a hemorrhage in both eyes. First and foremost, I would want you to identify where is the hemorrhage. And what I mean by that is what layer are we looking at? Is this a pre-retinal hemorrhage, subretinal hemorrhage, multi-layer hemorrhage? We can see that they both expand into a quadrant in the area at hand. Obviously, one eye will have more severe visual acuity than the other because the macula is involved. But both of these cases are actually very different, even though they look very similar. First case, 60-year-old male referred for possible wet macular degeneration. As I'm sure you both know, every time a patient comes in who is 60 and over with any kind of maculopathy, the diagnosis typically becomes AMD, and usually that's a great differential. Acute vision loss for 3 days, 2200, which is no surprise given the large hemorrhage in the macula. But what are we really looking at? There is a history of hypertension, which is going to become clinically important in this particular case, and the patient hasn't seen this PCP for several years. The most important thing I need you to note at this time is the fact that not only do you have a large hemorrhage, but you have a multi-layer hemorrhage. You have hemorrhages that substand into the subretinal, sub-RPE space, pre-retinal hemorrhage, and even almost like a subhyaloid-like or pre-ILM hemorrhage on there. Or should I say right underneath the ILM. There's some exudates, and there is this little lesion here. Is this a lesion? Is this a dehemoglobalized hemorrhage? What are we looking at? So any thoughts, anybody from the audience want to kind of gather any thought process? What are we thinking? Joe, Greg, what's your thoughts?
Well, I know what I'm thinking. I'm not going to tip my hand, but I think hypertension is a very important part of this history.
Agree, very much so.
I would kind of guide the audience, Diana, in trying to help, is look at the different layers where the layers of the hemorrhage is, if I'm just going to guide the audience. So.
And I think that's exactly right. You both hit the nail in the head on this one. So we can see that the hemorrhages, like I said, they are both superficial and deep. And as a matter of fact, sometimes you will get a dehemoglobalized area that will show up to be yellow within a hemorrhage. I often see it with old vitreous hemorrhage in our practice. But this here is an actual lesion and beautifully depicted within the OCT. This particular patient, and I'm sure both of you guys were thinking about this, a patient has a RAM, a retinal arterial macroaneurysm, which is nothing more than a large aneurysm which exploded. And in doing so, often associated with hypertension, you will get these multi-layer hemorrhages. There are not that many things that will develop these multi-layer hemorrhage. There is trauma, there is Tersen, Valsalva. Those are some of the more common ones, but REM probably guides one of the highest. In IVA, intravitreal Avastin, sometimes laser may be beneficial, but this one being so close to the macula, we don't often laser this. Any kind of key points you want to add in addition to what you had mentioned, which is the hypertension and the multi-layer hemorrhage, Greg or Joe?
No, I think the multi-layer hemorrhage is very important, and there's only a few things that will do it. Maybe there's a couple other unusual things will do it, but macroaneurysm is a huge one. So if you can identify where the hemorrhages are and the multi-layer hemorrhage, then you have a good thought. And hypertension, this is almost considered a hypertensive retinopathy, I think.
You're 100%
So
right.
to feed off of what Joe said, Diana, is that most retina stuff will bleed into two layers. So if you think about a choroidal neovascular membrane, It will bleed below the RPE, above the RPE, but it really won't bust through the retina and get into the vitreous. Maybe there's a rare case out there that's been reported. Most retinal things will bleed into two. So this one here bled into two layers within the retina, didn't really create a vitreous hemorrhage. And then neovascularization like neovascularization elsewhere, neovascularization of the disc obviously can bleed above the retina, into the retina, and into the vitreous space. So that's still kind of two, vitreal and then retina. And I have a case where I bled into all three, which is a Terson. So really the only thing that I can really think of that bleeds to all three is a Terson syndrome that comes down the optic nerve head sheath, can bleed under the RPE, above the RPE, and into the vitreous. So think of retina stuff as two layers, and that will help you guys out in the audience.
Those are great clinical pros. And just to go back, this one here was actually a branch retinal vein occlusion, and it can have kind of a similar appearance to here. But this is all superficial, just as you mentioned. And this small yellow area wasn't a macroaneurysm, but it was the dehemoglobalized area within, both associated with hypertension. One important thing from an urgency and an emergency case, it's not necessarily an emergency, but I would say it is an urgency. My doctors do like to inject subretinal, I'm in the choroid already, subretinal, sub-RPE hemorrhages faster, because those will especially if it was a neovascular membrane, there might be some fibrosis going on. Or even if it starts dehemoglobalized, it will produce a lot of damage. So from an urgent case, you do want to get these in sooner than later when there's a lot of blood underneath, not so much when they're superficial, which is one of the points that you had mentioned, Greg. Let's interpret these numbers here. We have careful with the numbers. Oftentimes I get cases sent to me that will say, hey, Diane, I think this is getting worse. The numbers here are getting bigger. Well, you can't get focused just on numbers. In an OCT, you have a lot of information. You have a B-scan information. You have so many other entities. And the numbers may vary just from the real, not just necessarily from the progression, but the dynamics of the changes at hand. This is a patient who was diagnosed with a central serous choroidopathy, 2020 minus today. Right before 3 weeks ago, they were being followed by an optometrist, and they were just following the patient, felt it was a central serous choroidopathy. There wasn't anything wrong at 2020. When they saw him 3 weeks following that, the patient was 2020 minus. Patient specifically stated that there was less blur, but there was more central metamorphopsia, which worried the optometrist, rightfully so. Did he get better or worse? What's going on here? Well, looking at the numbers, there's 334 originally, 471, but would certainly say, well, he's getting definitely worse. But let's look at the scans. The scans tell a different story. As you can tell, the widened area at hand, as it begins to resolve, it spikes up a little bit on the central area, as we can see here, giving it the peak from 334 to 471. But certainly we can see the dynamics of the area, hence the less blur. The patient is actually better. Centralized metamorphopsia is because the fluid is centralizing in the middle area, but the patient within another 3 weeks completely resolved at hand. Anything you want to add here, guys? Are you seeing?
Well, there's actually a question that came in about this. Will this likely occur again in the same spot?
Excellent. Not necessarily in the same spot, but certainly it can go bilateral and it can definitely reoccur. Many of the cases that I've unfortunately dealt with become chronic, and I don't have a great fundus autofluorescence here today, but they get this guttering-like appearance in many chronic cases that just leak and re-leak different spots at hand, not necessarily on the same spot. So it is a great question, and the likelihood of recurrence is very common, because unless it is associated with a specific, let's say it's associated with a steroid. I had a patient who was having injections on their arms and kept getting central serous choroidopathy on the same eye, leading to that arm with injections. Unless you take that away, most commonly is associated with stress-related problems, which are often there, no matter what the patient does. So recurrence is common.
So what happens in those recurrent cases? What are the best options?
Unfortunately, if you look at the studies, PDT used to help. Bascom has done cases where PDT would help, but most of our clinicians will not have PDT I don't think any of yours do. Greg or Joe, does your retinal specialist have PDT or do they use photodynamic therapy?
Nope.
No, and most,
My retinologist in Pittsburgh will do it, but geez, oh man, I haven't seen one done for a while. So
but that's actually impressive because they first have to keep the drug out of hand. If you're not using it often, then they essentially that drug will go bad. There's a lot of side effects with that drug, and there's an increased allergic reaction on those patients. So most surgeons at retinal practice outside of places like Bascom Palmer institutions will not use it. And that's often the best treatment, or at least some that has shown some effectiveness. Otherwise, there really isn't. Unfortunately, this is one of those diseases that's very common, but it does not have a very good treatment at hand.
I don't think they can even get the lasers or repair the lasers anymore, can they?
They've done for the PDT, you're saying, or have they
Yeah.
lasered before?
No,
No,
for the PDT.
I'm not sure since I never had one to begin with. I know Bascom does still use it because we did have a really pretty severe chronic case, and both my surgeons graduated from Bascom that work at the VA hospital as well. So they did contact Yanuzzi, and they did get the patient PDT, but I don't think it was that effective on that patient anyways.
And what about spirolactone?
Excellent, excellent. When I was at my previous retina clinic, and this is going back 5 years, we used to use it about 50 milligrams in a BID. It showed efficacy, but there was a large study that had been published. I'm trying to remember how many years back, maybe around that timeline, that showed that the efficacy wasn't really that proven, and the progression or regression of the disease was equal. So most doctors are not using, at least here, most of my doctors are not using that. Are yours, Greg or Joe?
No.
Yeah. I think
yeah, I've seen them do it on chronic cases. Yes. So
and that's not a bad thought process. And this is the point at hand. It is a disease that doesn't have a good option, but at the end of the day, we as optometrists need to identify it and send it out to see if the retinal specialist could potentially do something for it. As it was proven, Greg does have a retinal specialist, does. My common ones don't. Greg does. Joe's, you're gonna confuse me with that. Joe's doesn't. But at the end of the day, I think it becomes our point to at least get the best option at hand for the patients. Now,
yeah, the retinologist group that I work with down in Pittsburgh, Diane, I mean, they have a bunch of offices. They're very, they do a lot of, I think a lot of them came out of the Bascom area, the big retina areas, and, they do a lot of the studies still. And some of the guys are the older guys and, around when the PDT was around for AMD. So they still keep it around for for the kind of the tough cases. Yeah. So.
Well, that's great because at least there's options. It's been terrible when you don't have answers. I have a patient who looks like there's a motorcycle going in on all these different humps, and patient is 2200 and they're trying to find answers. And he's actually bilateral. He's 20/40 on the other eye. And there's really not much to be done with them. Now, this was a really interesting case. And here's why, because I think it was us who were really the ones who really helped the patient. Now, the patient was actually seen by two pediatric ophthalmologists in the past, and this was years ago. Then they were seen by various different offices, various different other doctors, optometrists, ophthalmologists. But here's the story as it goes. They were referred to us for possible optic nerve head drusen. It was a 14-year-old, and I'm not good with pediatric cases. I don't usually deal with pediatrics at hand, but this was one of those cases that they asked me, "Hey, Diana, will you see?" And I said, "Sure, let's see what happens." So prior to seeing this patient, we had asked questions, we had gotten some information out from the mom, but the patient had headaches and a tinnitus of the left ear. They had dark adaptation problems, which don't usually correlate with, let's say, papilledema, optic nerve head drusen. 20/30 best corrected. Yet another thing that doesn't usually correlate, at least with the early papilledema cases, those are usually 20/20 cases. And when the nerve starts dying off, which is why it becomes more urgent at hand, the patient starts losing vision. Now, here's what's important. And again, I don't deal with children, but she was cognitively, what I would say, immature. And what do I mean by that? She's 14, and it was like talking to a 5-year-old. And you guys know and understand what this is all about. So there was something off. But no matter what I asked the mother, she said she was absolutely fine. She was slightly overweight, evaluated at a young age, I think age 2, for some sort of syndrome, to which I asked why, and she said that she had an extra digit cut off at that time, and there was nothing stated about any other problems with the syndrome. She was put on growth hormones because she was quite short, and her sister also has dark adaptation problems. Now, putting all this together now starts telling you, is the nerve the only thing I'm going to be looking at? First and foremost, when it comes to papilledema and drusen, would this just scare you both, Greg, Joe? I mean, we're looking at 211 microns of nerve fiber layer increase in one eye, and we're looking at 331 in the other. I don't think this is even questionable when it comes to swollen nerve. Not saying papilledema per se, because papilledema is increased intracranial pressure. We're not saying this, it could be papillitis and many other entities. But as far as a swollen nerve, there's no question here. I don't need an OCT to tell me that. Now, oh, and one thing I do want to add here. If you have, this is a good clinical pro, if you have a patient who is young, 18 and under, what you should do is I save the original data at that age, but then I make the child 18 in order to get my regular normative data colors here. The colors will not show anybody who's 18 and under. So I usually say both data points, especially with optic nerve head drusen that I'm following up over time, in order to be able to get my nice little normative data graphs on here. Now, looking at this and why I put this picture up on the top, I see an old lady and a young lady. Why am I showing this? The nerves are swollen. Let's take that out of the equation for 1 second. Looking at the retina, this is not a normal retina of a 14-year-old. This glistening area is what I expect to be normal. But this area is here, although it was not very obvious, it's dystrophic. This is a raggedy looking retina. And if you look really carefully, you see this little pigmented area, you see here this little pigmented area, these are going to become important. And I'll show you particularly in the fundus autofluorescence. OCT here gave me a perfect clinical picture. This is not normal for a 14-year-old. Greg, Joe, what would you say is going on here? What would you think?
It's very thin.
Extremely, right? And notice that kind of almost like a half bullseye-like appearance on the not necessarily called the ANFOS, but on the maps on the top, the color maps, the heat maps. It is extremely thin. This is not a Heidelberg, this is a Zeiss. On the Heidelberg, I'm able to actually see much better, I think, the delineation of the PIL, or at least I should have gotten an HD OCT to see it better. But certainly here, the PIL, the ISOS line, is still preserved subfoveally, but it's completely gone in the outer retina, and there's some severe thinning as well. And as I told you here, there's some pigmentary areas. Look how beautiful the fundus autofluorescence displays a lot of the changes at hand. So what are we potentially thinking of? Anybody want to say in the audience, are there any guesses out there? We're looking at a patient with dark adaptation. The optic nerve head swelling is going to be displayed separately in our thought process in regards to what's going on here. Seems to have a family history, and they used to have an extra digit that was taken out. Any thoughts? Anything out there, Joe?
No, nobody's coming in.
Okay. Well, this is the beginning of RP, but it's a...
Oh, someone just put it in. RP question mark. So there you go.
Great job. Great job. So when it comes to a child, someone who's young, the RP is not going to show with the typical triad, the bone spiculings, the pale nerve, the attenuated vessels. As a matter of fact, the nerve was swollen. It's hard to tell if it was pale. There was definitely no attenuation of the vessels. But the abnormality of the genetic insert on this patient starts killing off the outer retina, which becomes dystrophic. That in itself, the retina is insulted, will bring in pigmentary changes, which would allow for these pigments to start forming the bone spicules across the vessels. Thinning retina, the vessels do not have to give as much oxygen, so they become attenuating. And as they feed back to the optic nerve, you get a waxy, it's not actually an optic atrophy, but it's a waxy glio-like effect of the nerve. What's happening here is she was potentially, we ended up working this patient with Dr. Mendoza up in Bascom, but the patient had a syndrome that was not diagnosed, and it was incredibly important because patients will end up having all kinds of kidney dysfunction and various other entities. And the optic nerve head swelling, obviously everything was done from the MRI, the MRA, et cetera, was likely attributed to the growth hormones that she was taking again. So it was really an interesting picture how we put the whole entire thing together. This particular patient who had been seen by numerous doctors, but was never stated to have anything wrong. And RP can be missed very early on in these patients. And now her sister is being evaluated as well. Any questions out there regarding this case? Any comments, Joe, Greg?
Well, you didn't really show the optic nerves and how swollen they were. Ultimately, I assume this person was evaluated for. See, it's hard for these are hard for me to see.
Yeah, and you're right, and I could have made him. Unfortunately, had optos, but in the scan, we certainly looking at numbers of 211 and over 300. We know that they were severely swollen.
So I assume that she was worked up for pseudotumor and real tumor, correct?
Correct. The first thing that they did was the MRI and the MRA. We sent her directly. I had actually spoken to the ER doc, and then we got him directly to Mendoza within 2 days. So yeah, 100%. That would have been that's the first thing you have to rule out on this patient for sure. So getting back to OCT at hand. OCT, oftentimes I get cases, and I'm sure Greg and Joe, you guys get this too. You get an OCT and they go, what is this? And it's hard to sometimes make a determination without a full clinical picture. Give me an age, give me an ethnicity, give me some signs or symptoms. Let me look at the photo at hand so I can make a determination. But here are some common conditions and see if the audience, and I'm just going to give them a minute to kind of evaluate to see if you can make the clinical diagnosis. We are going to go through all these cases at hand, from variable macular edemas to variations of holes to variations of tractions, etc. But there is, what I want to get to is that there's not like a one size fits all. Even though this is probably a common VMT, vitreomacular traction, there are different perspectives and different views that we will see throughout. Unlike an epiretinal membrane where you have a tangential force across the area, variations of fluid from central serous to CME in someone who's diabetic, who's got a CRVO, exudates or areas that are going to show up as hyperreflectivity, full thickness holes to lamellar holes and pseudo holes at hand, and variable presentations of choroidal neovascular membranes. But we are going to talk about throughout the lecture today, all the variable cases at hand. So, like I said, it's not one size fits all. Idiopathic macular telangiectasia, it's a great disease to give you a perspective that I can't tell you just by an OCT the patient has JRT, juxtafoveal retinal telangiectasia, idiopathic macular telangiectasia. Certainly, and I'm sure Greg will agree, with the OCTA, you definitely can make the clinical diagnosis, and you certainly don't need an FA for that. But depending on the variation of staging, the presentation, and the findings, any of these OCTs may correspond to someone who's got macular telangiectasia. This is probably the most classic draping of the ILM with this collapsed cystoid-like changes, but the outer retina may be involved without inner retina involvement. Oftentimes, they could develop dystrophic and atrophic areas throughout, even an atrophic-like macular hole. And as the telangiectatic vessels continue to communicate inward down, choroidal neovascular membranes can occur. That is usually the time that we do implement treatment. Prior to that, we don't. There is an FDA-approved recent treatment, but I don't see many retinal specialists using it nowadays. Have you guys seen it? The newest treatment for JRT, any of your retinal specialists, maybe Greg with the institution?
Yeah, I haven't seen them I haven't seen a patient of ours. I have to call them and ask them if they are. We talk about it in our pharmacology lectures, but I haven't seen it implemented yet.
Yeah, neither have I. We haven't even sent one to Bascom for treatment at least as of yet. But here's an example where a lot of things can be happening in one single patient. This is a high myo patient, but there's a lot of stuff going on. You got a thinning of choroid. You have traction pulling up into almost like a bridge, opening up the area of this lamellar-like hole. You can see the Mueller cells stretching throughout, a very large staphyloma. There's still an epiretinal membrane with tangential traction throughout. So there's a number of different things going on in one single case at hand. When you look at an OCT, you need to manipulate the areas and evaluate them side by side. In addition to, I would never look at only one single scan, because if I cut this in a different way, I may miss the macular hole. I may miss a choroidal neovascular membrane. I may miss edema. So you should look at the whole entire video at hand. And I often do, especially on Zeiss products, for example, both an HD and a regular Mac cube, giving me information not only of all the lines at hand, thickness, as well as the highest definition per layer. Any clinical pearls that both Joe or you want to relate in regards to acquisition and obtaining the scans or evaluating them?
No, I'll just echo what you said is that, if you kind of take a raster or take a cube data and you look at it, you might go from a macular cyst to a macular hole, depending on what cut you're looking at. So, most of us just open it up, kind of look at it, but go through the cubes, go through the different cuts, and you make sure you get your true diagnosis by not just looking. So just echoing what you said and just saying it again in a different way. So I agree with that 100%.
Yeah, it's like looking at a CT or MRI. You have to go through each of those millimeter cuts.
Excellent, excellent. And I like how you said, Greg, saying the same thing, but a different way. You sound like my husband, except he thought his way was better. Anyways, 67-year-old, this is one of my favorite cases because this is one of my very early cases at hand. And I loved how I saved the letter from the retinal specialist. It kind of in tunes to the fact of how invaluable OCT has become. 67-year-old patient here has come back for a 6-month follow-up for dry AMD, 20/30 and 20/50 plus. Patient was not complaining. And I think that's important to note because if a patient comes in, I don't care if they're 20/20, but they're complaining about that 20/20 eye, you want to investigate that much more carefully. But this patient was not. And in doing so, once we're looking at the pigmentary changes here, we're looking at drusen. And I think his visual acuity on the left eye was maybe 20/40 minus previously. Now you're 20/50 plus. So it's not a big difference at hand. So we're going to look at this particular area a little more carefully. And in doing so, the OCT, and here's the ENFAS, which to me was kind of like the development towards the OCTA, delineates this particular hyperreflected area above the RPE and subretinal very, very well, which is obviously a choroidal neovascular membrane. We obviously do have some fluid, some pigmentary changes that have dissipated from the RPE and forward, but there's very limited thickness, and the visual acuity hasn't changed. This is what I found to be really interesting. And this was the actual letter from the retinal specialist. He himself said, I saw him after I did my exam, and I did not think there was going to be anything wrong with the patient. It was only after I saw the OCT that I was surprised. So I actually thought that was quite impressive that the retinal specialist word for word wrote that towards the particular case at hand. And this was going back many years. One thing I do want to add here, if you don't have an OCT, for that 20% that doesn't, I want you to look at the retina a little more carefully. And in doing so, look at the pigmentary uniform area for the right eye. Notice here a little bit of cloudiness coming through, and you don't see that pigmentary area as well. That is because it's as if you're looking through a glass of water and you're looking right through the area. It desaturates the color. So that itself was the small thickness that we were seeing on the OCT. So it's a little important to evaluate the macula even more carefully if you don't have an OCT. 79-year-old here with decreased visual acuity. Another patient did not notice any decreased vision. Is this a choroidal neovascular membrane? You have this yellowish-like lesion in an older patient, a maculopathy. Certainly, it could look like one, but the OCT reveals that, in fact, it is not. You almost look at the formation inside of what I call almost like a lava lamp appearance. And this is lipofused and enveloped within an RPE, which is a form of the vitelliform. In this case, what's known to be pseudovitelliform. Very common even in our AMD patients who have dry AMD and oftentimes refer to us for diagnosis of wet AMD. This is a wet AMD patient. So what you notice here in the RPE, it is now well delineated. Even if it was a PED, it's got this elongated-like form that is disrupted with subretinal fluid, and there's hyperreflectivity underneath. That is a choroidal neovascular membrane, and that patient is likely to be symptomatic to some degree. Mild decrease in visual acuity, metamorphopsia, etc. Anybody want to add anything to that? You guys see a lot of we see them all the time, pseudovitelliform, adult vitelliforms, and even Best disease in adult stages. Do you guys see it often?
I do not.
Yeah, I've seen over the last few years, the telangiectasia patients and the
Pseudovitelliform?
yes, the vitelliform patients come in, and on top of it, I have, as you get, Diana, and I'm sure Joe, we get OCT pictures sent to us all the time, and it's just adult vitelliform. I mean, it's just a big uprising in a sense, maybe related to our pandemic, maybe not, maybe to the treatment. I don't know, but it seems a lot of increase in both of those conditions.
Yeah, definitely. It's a good point. It could also be the fact that we're getting better at diagnosing. That maybe the condition had been there for quite some time and we're diagnosing as something else. 45-year-old white male, unilateral presentation, visual distortion. So now this patient is symptomatic. And as I mentioned to you, anytime a patient is symptomatic, you've got to look at things a little more carefully. You're also noticing a small little red area there. And that in itself, you have to start considering a hemorrhage, first and foremost. Any kind of hemorrhage within the macula, one has to suspect a choroidal neovascular membrane. This patient did have a vitelliform years ago, and vitelliforms can develop the choroidal neovascular membrane. Anything disrupting the RPE can always develop a choroidal neovascular membrane. And as you can see here, you can see the hyperreflectivity disruption through the RPE, the subretinal fluid right adjacent to it. The fact that this patient is complaining of distortion is a hemorrhage. I don't need an FA to determine the fact that this patient needs an injection. Now, the ones that make me a little bit more concerned, but almost invariably these patients will complain of symptoms, are the small choroidal neovascular membranes, probably even more common on the high myopes. They develop some very small neovascular membranes. They do not disrupt the retina tremendously. Just like this little tiny lesion, you can see that the disruption of the RP is right underneath it. You actually even have some hyperreflectivity right underneath that area. Some RPE disruption adjacent to it, but there is no fluid. And although peripheral drusen is seen, there's really not that much drusen involved in the central area. But looking carefully, there's definitely a disruption. This patient will benefit at least from an FA. And right over here, the FA does show the increased autofluorescence, the increased hyperfluorescence on a patient, signifying leakage. It is not pooling. With a central serous, the pooling will show as increase in the brightness of the dye. With increased leakage, not only would increase in the brightness, but it would also spread outside of the area in question. In an autofluorescence, say in a piece of drusen, it's just going to be the same brightness and the same size throughout. That's the difference between pooling, leakage, and autofluorescence when we're seeing it through the FA. But this is a very small choroidal neovascular membrane, and one could miss that. I would have more likely have called this a pseudovitelliform than the original one that I had shown you. But one has to be careful with evaluating the RPE change underneath that. And if the patient is symptomatic, you always got to get a second opinion on a patient. Anything you want to add there?
Just the value of OCTA. That's, I mean, we go back and we have the 75% of the audience that has an OCT now, and I agree. We used to raise a hand, and 10% of the audience would raise. It just kind of shows us how old we are too. But we'd see the audience just kind of rate. Most of the audience has it, and you have to remember, why did we get it? So that we could see the things that we were confused about, and that's what OCTA answers for us. It allows us to see these vascular changes in diabetes and macular degeneration. That's the two valuable points of OCT. It's okay for glaucoma, but all these macular conditions and where there's choroidal neovascular membranes and diabetes is where I find the value because they're vascular diseases and we can now see what we're looking at. So
Yeah, that's actually a very good point. We obviously don't use OCTA because I have an FA and looking at things in a dynamic point of view, but I think it is an invaluable source. And nowadays we even have a code that is above the OC. I don't remember. Do you guys remember the pricing now that you get the reimbursement of OCT versus OCTA? Because I know there's
yeah,
a,
it's around I think $45 or $50. I think it's 92137 is the CPT code, but
but I think the
um,
OCTA is separate now. There's
it is. Yep. Yeah. Yeah. I think it's around 45 or $50, maybe 60. I don't remember, but it's 92137. You are correct. It does have a separate CPT code.
Okay. Now, this patient was referred for injections for wet AMD. Patient was diagnosed with macular degeneration age 50. So that already kind of clues me in. Am I thinking of something else? 50 is a bit young for macular degeneration. It's not to say that I haven't seen macular degeneration in younger patients, but 50, in my opinion, is a bit young. And obviously, being in that age group nowadays, I think it's really, really young. We actually used to think that 50 was old. I would look at my parents and I'm like, oh my God, you're 50? Now I'm like, oh my God, you're 80? Okay, 2040 right eye, 2025.
Hey, temporal arteritis is on the menu for everybody on this call.
I know what kinds of things we have now on the menu. Anyways, 2040 plus right eye, 2025. There is what seems to be the greenish-like lesion that we've been describing in the past during our academic years. But in looking at this again, a little bit different than the other one. I can almost let you know the first one, I wish I should have put the pictures side by side. The one that was a small choroidal neovascular membrane can look like this. The difference is it's a much more well delineated circular area. And here with the vitelliform, you almost can see the substance because it is a lipofuscin substance within the area, just like I was describing in the lava lamp. But regardless, the patient had been injected in the past. And what do? We do an FA. So for us, it makes it easier. This is not the area in question. This is an area of autofluorescence, some sort of RP atrophy within that area. Right over here, there's absolutely no leakage seen. And when following up the patient within 3 months, it was completely stable. And the patient previously had been injected numerous occasions and it remained stable throughout. So this was nothing more than pseudo-vitelliform. So poll question number 2, Greg. Which of the following is likely a benign sign, which may be, hold on, because I got you on the picture here, so I can't look at it. Okay, which of the following is likely a benign sign, which may be attributed to intermediate dry AMD rather than wet AMD? All the other ones as shown here outside of this one will likely be attributed to wet AMD. So which one is not wet AMD?
Polling question is open. Joe, are there any questions? Anything in the
Nope.
chat box? Any comments?
Nope. Nothing new. No questions.
Okay, they're rolling in nicely here.
I won't say this one's easy, but we will show you pictures of all of them.
All right, so looks like you have a tough one here. They were slow to roll in, and
It's
they're
definitely not easy.
but it looks like the trend is set. We're close on 2, so I'm going to see what happens here in the next second or 2. All right, it just flipped. All right, so let's see. I'll display it. We have A at 41% and C at 42. So your highly peaked sloped pigment epithelial detachment, that just went to 40. RPE modulation is 42. But then we went subretinal fluid is 6% and hyperreflective lesion in the subarachnoid space is 12. So kind of A and C are kind of just flipping back and forth at 41, 42, 42, 41. So those two are tied.
And this is why I put this together. You'll see some cases at hand, but it is RPE modulation. So just small multiple elevations within the RPE. So this particular one, that highly peaked PED, oftentimes has hyperreflectivity underneath and commonly associated with choroidal neovascular membranes. And I'm going to show you a couple of cases of that. These very large slopes of PEDs here, rather than having a really small PED, commonly is associated with polypoidal, which is nowadays believed to be some form or variant of the choroidal neovascular membranes, even though it really is a polyp within the choroid. Again, treated the same way as choroidal neovascular membranes. The hyperreflected areas, those are the ones that we talked about for in the past. Whenever you have a lesion coming into, and it's a single lesion coming into the subretinal space, one has to consider that a choroidal neovascular membrane must be that lesion. And these elongated or irregular PEDs. So rather than just having one, but it almost has like a double hump appearance, often associated with a choroidal neovascular membrane. So all these are. Now, the ones that are not so scary are these multiple, what we call RPE modulations. They're nothing more than bumpy bumps throughout. So when you have a choroidal neovascular membrane, you definitely might have RPE modulations because there's associated drusen. But those associated drusens are not the choroidal neovascular membrane at hand. Here we have a typical PED in association with a central serous, and here's a very small PEDs. And by the way, these PEDs, they don't have treatment, and oftentimes they may be there for years. We don't do anything about them. We just watch them. Amblyopic patient here, high refracted error. They've been 2200 for a very long time, but the patient did notice a mild distortion about 3 days ago. And I will tell you that your high myopes, regardless of their visual acuity, almost invariably will notice metamorphopsia, mild blur. They're very picky about their vision, regardless of their visual acuity. You're looking at this whole entire picture at hand, especially on the optos, that is not as highly magnified as some of the other images at hand, and it looks like a hot mess. It's kind of hard to tell what we're looking at. We have some pigmentary changes in the macula. This whole area right over here, I'm delineating the staphyloma. There's depigmentations probably from the stretching. There's a PVD here. But the most important thing at hand is that the patient is symptomatic. Anybody with acute symptoms coming to your office, you always have to look at them yet a little more carefully. And here you can see the hyper-reflected area, as we mentioned before, above the RP. Patient also has a very large staphyloma. There's an epiretinal membrane, and you can see the elevation in the retina from the push from underneath. This is a choroidal neovascular membrane. I'm not going to worry about the type 2s and type 1s, but what I want to do enhance is the fact that myopes often have a small type 2 choroidal neovascular membrane with very little leakage. So you won't see hemorrhage, you won't see much fluid. They're just slightly symptomatic. The good news about the myopes is, for my surgeons, is they will inject them typically once a month for the first 3 months, then treat and extend, but they don't have to treat and extend forever. They may, in some cases, need more treatment, but unlike AMD, this kind of dies off to some degree, and especially being these young patients who are much harder to get into the office. What I also want to allude the fact, especially now with myopic control and seeing more and more patients with myopia, that it's not just the periphery at hand. It's not the tears and the retinal detachments that we're worried about, but a slew of maculopathies. And they're not just neovascular membranes. They can develop holes. There is a whole entire world now known as myopic tractional maculopathies. So looking at the OCT of patients who are high myopes becomes very, very important. Anything you guys want to add?
I'll just add that, again, just echoing that these usually are treated, 1 or 2 shots, maybe 4 or 5 shots going out a year. Really, because anytime you disrupt Brooks membrane RPE, you get that risk of a choroidal neovascular membrane, but it's not like an ongoing inflammatory immune process like that's happening in macular degeneration. It's more of a stretching, a signaling, a crack out there from the stretching. Things kind of scar, fall into place. You're just kind of using the anti-VEGF injections to kind of keep things from getting really bad. And if you want to say it burns out, because there's really no chronic underlying oxidative stress poor lifestyle. It's just more of a stretching where, it's the macular degeneration is more of an autoimmune and chronic inflammatory type of condition, which requires the ongoing treatment and stent treatments. So they do burn out.
Excellent point. So this is a 36-year-old white female presented for evaluation of bilateral central serous. So I kind of get a little wary to think, not to say that women do not get central serous, but I already got two strikes here. One is the fact that it's bilateral, and two, the fact that she's a woman. So I have to start thinking of potential differentials, even though central serous is definitely a differential at hand. She's mentioned, in fact, that her visual acuity has been about 20/30 for some time, but perhaps it's gotten worse over the last 6 months. And you have this flattened out appearance of the macula in both eyes. Now, I thought this was a wonderful fundus autofluorescence, and I use fundus autofluorescence often. If you guys have it in your machines, I will encourage you to get it on every single time you get an Optos photo, or any kind of photo that you get. Doesn't necessarily have to be from an Optos camera. But if you have it, it really does delineate a lot of information that is not as obvious when looking at the dilated fundus exam or photography. But over here, you have what's called a corona-like effect. So if I'm looking at a crown from the top, I can see the hyper-reflected peaks on the surrounding the area in question. You also have this sedimentation-like appearance with hypofluorescence on top and hyper on the bottom. So there's some sort of fluid that is leaking downwards, separating from the top part that has been disrupted. So it really does give you a very good clinical picture of what we are looking at. Looking at the OCT, this looks very different than typical central serous. Why? Two particular areas in question. There's a thickened hyper-reflected area, and there are these deposits hanging on the belly of the retina and above the RPE, which are common with the disease that we're looking at. So why is it not central serous? Like I said, not to say that females don't get it, but it's far more common in males. There is no precursor in this patient, such as stress, pregnancy, sleep apnea, etc. Seems to be a more gradual onset rather than acute onset, even though central serous can become chronic. And it is a bilateral presentation rather than more commonly, at least in the initial presentation, for a central serous to develop as a unilateral presentation. Another common thing that an OCT can give you that's very helpful in the ICSCs is these very thick choroids. These choroids become so thick, they're about 500 microns. If you cannot see that the fovea and the macula is about 250, it is putting together two foveal areas underneath. Why is this important? Is because you will get older patients who have this thick pigment epithelium that will develop these chronic central serous. They are not wet AMD. And by looking at the choroid, you sometimes can identify these AMD patients that have central serous who have much thinner choroids, as opposed to somebody who's got polypoidal or central serous choroidopathy that have a very thickened, what we call a packing choroid at hand. But our particular patient had Best disease, not a pseudovitelliform, the actual vitelliform, which goes through staging at hand, forming from the vitelliform or egg yolk appearance to where she is now, the pseudohypopion. And you can see that in my patient, you had the hyper-reflected area of fluid underneath. So what happens with this vitelliform is that as it begins to progress, the RP disrupts and almost opens up. Some of the fluid, the lipofuscin, leaks out, and you're only left with half of it, giving you this pseudohypopion, like a hypopion assessment. With that, over time, the eye moves, it scrambles itself within the space, and you get the vitella erupted, and eventually you get the scar. Now, here's where it became really important and interesting. We did ask her about, we got the genetic testing, and it showed that she had the bestrophin gene. We asked her about children, to which she said she had one kid who had amblyopia. So I said, okay, well, can you bring your kid in? Again, not a pediatric person, but I wanted to make sure we were doing right by the patient and their family. So the 5-year-old son, and believe it or not, you can get great OCTs on kids. And there are games that I usually play with them where I'll say like, oh my God, look inside, Spider-Man's about to jump out. And they'll look really carefully to try to assess this green goblin or the Spider-Man. So you will get pretty good evaluations, even on young children. And her child actually had undiagnosed vitelliform just as well, with 20/50 visual acuity. Not to say that they didn't have amblyopia. I'm sure the 4-diopter hyperopia they had an amblyopic component to it, an amblyogenic component, but at the end of the day, the patient also did have Best disease. Any questions?
Nope.
Describing the scene. This patient was injected and diagnosed. So a lot of times we'll get people from South America and other countries, and maybe they don't have all the diagnostic modalities at hand. And therefore, maybe that's why our first patient and this one had been injected over time. But this patient had been injected for several times. I don't recall their age, for choroidal neovascular membrane, and it was unchanged. Now, what I'm noticing here, first and foremost on the OCT, that kind of bothers me a little bit about evaluation of a choroidal neovascular membrane, is the fact that even though there's a very large PED, like we talked about, these very large slope PEDs, the retina above it looks dynamically disrupted. What do I mean? It's elevated and it's stretching. So you see the Mueller cell stretching. That's a macular schisis. And that's not common with a choroidal neovascular membrane, as Greg alluded to before, separating the retina from the subretinal space or right above the RPE and the intraretinal space. This has a component of both. And in looking at further, there was a very large pit in association where the fluid was coming from, attributed to this macular schisis subretinal fluid coming from a pit. This will not benefit from anti-VEGF treatment. As a matter of fact, the common things that we do for these patients are going to be surgical. Laser has been done to the area close to the pit to almost sealed off where the fluid is coming from, tamponade gas in order to flatten out that very large elevated area, ILM peeling, as well as vitrectomy. This other patient was another patient of one of my surgeons. Look at the massive PED and the huge macular schisis. Patient was evaluated over a period of 6 months, resolved completely on their own. So they can actually resolve right on their own just as well. So I've had some interesting cases, particularly with the time that I've actually been in the retina clinic, which is now about over 10 years. 61-year-old referred for ICSC. We're looking at, and then just like you mentioned before, Greg, this is going to go right back to the case you said. Don't just look at one scan. You're sending me the scan and you're telling me the patient has central serous, had a death in the family under a lot of stress. Well, yeah, it makes sense. And it definitely looks like a central serous. But in looking at the overall picture at hand, the original scan was taken through here. Now I'm taking a scan through this area in question. You can see that is elevated, all the superior aspect. And again, look at these type of deposits, very similar to the vitelliform deposits because they're also lipofuscin. Remember, best disease is a lipofuscin disease. And here you have these orange-like pigments throughout this very large area, and there's fluid underneath. I'm crossing over right through the superior aspect. This patient has a massive mass on here. So even though there was definitely fluid into the macula, leading to an example of a central serous, what the patient really had is a melanoma. And as a matter of fact, it was metastatic. As you can see here, this leopard-like appearance, this was also metastatic. The patient had failed to admit to the fact that they had lung cancer and stopped treatment for over 6 months because they believe it just wasn't helping them out. So it led to the metastatic cancer in both eyes. Another thing, and I'm going to add to this later, but OCTs I think are helpful for small choroidal lesions or even small melanomas. They're not often incredibly helpful for large melanomas, and an ultrasound is still definitive and very important to get. But one thing I want you to see here, which will become more important when I show you some of my freckles or nevus at hand, is these are the choroidal capillaries here and here. Where the lesion is, even though it's elevated, it's hard to tell how far it goes from here all the way down. But the choroidal capillaries become compressed. So when you're trying to evaluate, say, a nevus from a chirpy or something else, if you look at the choroid, there will be a lack of choroidal capillaries where the lesion is, if there is indeed a lesion at hand, because they will become compressed. And I think there's some really good, helpful things where an OCT can become invaluable in looking at small choroidal lesions, and particularly at nevus, to follow up change over time. Here we're looking at something, a photo with a white lesion, and then looking at the vessels, it almost looks like it's elevated, but it is inundated, and this could be nothing more than a scar or a coloboma. Example of two, obviously, it's a little bit less obvious, but you can see very large areas here of white. This one is definitive elevated, and this one is inundated. Here we have a large coloboma, can definitely see it on the OCT, and here we have an elevation. Just like Greg mentioned, this is all about anatomy. An OCT gives you an anatomical perspective of every single layer. The way I describe it to patients, and I think it's very helpful, I take my tissue box and I show it to them. And I say, when I'm looking at your retina, I'm looking at the tissues. If I'm turning my tissue flat and I can't see what's going on. But if I look at my OCT, I turn my tissue on its side and I can look at every layer of that tissue making up that potential problem at hand, and could tell you exactly where it is and what is going on, and therefore helping me with the management and treatment. Here, the two areas can look very similar. But what did I tell you before? That if there is a choroidal lesion, the choroidal capillaries, as you can see here, will be compressed. Right here is where your lesion is. This looks elevated. Any one of you two, anyone, I want to go out there and say this is not a lesion. I'm going to tell you guys that automatically. But I want to see if anyone for the audience knows what this is on the superior aspect. Notice the choroidal capillaries are intact. So you know it's not a lesion, but it's definitely elevated, except it's not an elevation coming from a lesion in the choroid.
While we're waiting for the audience to weigh in, I'm just going to clarify, because I was clarified by my retina docs. I work with them pretty closely in Pittsburgh. They know I geek out. I used to work in a retina clinic. So they like when I send them stuff, because it's usually what I send them is what it is, and so on and so forth. So the metastatic, I was calling it a choroidal melanoma also. When I said, oh, I got this patient, they have lung cancer, it's metastasized to their eye, it's a choroidal melanoma. And they're like, Greg, it's kind of, we're saying tomato here. Choroidal melanoma, when we see them and it's unilateral, developed in the melanocytes, it just happens to be a choroidal metastasis. It's really not, if it's a lung cancer that has metastasized to the eye, it's not melanocytes in a sense. So basically, it's cancer. It's in the, you can call it choroid. But when I was, talking to my retinologist, when I sent it over, they're like, Greg, we're just splitting hairs here. We're just having an academic conversation. Choroidal melanoma is melanocytes. Choroidal metastasis is just happens that the lung cancer cells have traveled, the cancer has traveled to the, so it's just choroidal metastasis versus choroidal melanoma is what I'm saying. So.
And I think it's also very important too, from not necessarily from our perspective, but from the management perspective. When you're looking at the eye, you want to prevent any metastatic from the eye, particularly going to the single place that most commonly goes is the liver. So identifying a very small one and that could be treated. And I can tell you from a personal perspective, because my uncle, I had diagnosed him with a small melanoma at hand, becomes incredibly important. On that particular patient, sadly enough, that patient already has cancer elsewhere. So the eye is not, it's the least of the trouble, knowing the fact that it's metastasized somewhere else. So it is a very good point about the primary melanomas versus metastatic from elsewhere. So anybody weighed in on the top one? How about if I
the three things that came in dome-shaped macula, hemangioma, and osteoma.
Excellent. I am so proud of them. Thank you so much. You're 100% right. And the other two differentials, very, very good at hand. It is the dome-shaped macula, but the other two differentials, both from the osteoma as well as the hemangioma, are great differentials at hand. And I will present a hemangioma at the end if time allows. And one thing about the osteoma is that they usually get this lamella-like bone. So there's actually a separation on the superior aspect above the RPE, but great differentials at hand. The difference here, as I mentioned before, the choroidal capillaries are still intact, and this is a dynamic difference where there's actually staphylomas, mini staphylomas above, and there's a bulging of the central area with staphyloma. So it's more of a dynamic presentation as opposed to actually having a tumor pushing forward. Looking at the coral capillaries become very important. How else can an OCT help with lesions? I always get a OCT. Do you both get OCTs on small nevus and any kind of choroidal lesions, if possible? Obviously, if it's way out there, you may not be able to. But when around the posterior pole, do you? I see
I do,
Greg's.
yes. Yep, I do.
Occasionally, yes.
I find them to be really valuable, and here's why. This was believed to be a potential small melanoma. Because at the end of the day, a melanoma is not going to be 5, 6, 7 this diameters. That's not the one you're going to miss. The little one that could either grow over time or change, because there are two variations. Either it transforms to melanoma from different melanocytes, and or it is a small melanoma to begin with, and it grows over time. That was Shields' work that he did for TFSOM, I think. I'm not very good with mnemonics. I don't memorize. But nonetheless, I think it's invaluable to look at findings that may be related to a small melanoma as opposed to a small nevus. Here's a great example. You got something that's about a disc, let's say between a disc and a half, disc diameters and sides. Both of you guys would agree, correct? But are we looking at anything that we don't like? We are. We're looking at one thing, there is fluid. Probably less than 16% of nevus will develop fluid. We're also looking at this orange-like pigment. And we know the lipofuscin is a phagocytotic activity telling you that something is happening, something is changing. We don't get that with nevus. There is a small elevation, as we can tell here, but I can't give you the appearance. And nevus can have a small elevation, but by looking at things and you identify fluids, what we call a shaggy PIL, which was the example that I gave you with the metastatic that had those little tiny deposits on the belly of the retina and right above the RP. That's what we call the shaggy PIL, as well as LA elevation. We may be potentially looking at something that's going to grow over time, and this being a small melanoma rather than a nevus. So I would urge somebody to get a second opinion on a case, even if it is very small. Anything that either one of you two want to add to that, or anything from the audience?
What I would add is why I like getting the OCT image, because it might not be valuable for my initial workup, which it's always valuable. It's whatever you're trying to determine if there's change over time, right? So now I have a picture that I can look at and an OCT to help me determine if these changes are occurring over time when we're following these patients.
And this is also why I put this. It's not going to give you an exact measurement, but you can have calipers and actually try to gauge your calipers where you want, and you may be able to even see any change in size. If you don't, on a photo, always look, because it may be very difficult, subtle changes, for areas that show you distribution. Say where the vessel is distributed out, that's the end of this area. If anything starts growing beyond this area, then you know it's growth. Because sometimes it may be very hard to look at very subtle changes at times. And we've had several nevus, those so-called that we thought were nevus, that had changed. So things happen. Another thing that I wanted to let you know is when you're looking at an OCT and you're looking at the ENFAS, especially if you have a technician trying to take the picture for you, the colors change. So if it is a pigmented lesion on the ENFAS, it will look hyper, whiter, hyper autofluorescence, and opposite for the whiter lesion. So if they're looking for something, the color is going to be different distribution. And sometimes they'll have hyper or hyporeflectivity underneath. Here we can see a flat nevus. There's an RP modulation, which likely associated with one area of drusen and a little bit of an RPE change, but we can tell this is relatively flat. Again, look at the coral capillaris, how they disappear where the lesion is. So even though it's flat, I can tell you exactly where it is, and I can put my caliper right over here to over here and take an exact measurement at hand. Here we have one that's associated with hyperreflectivity, and again, there is compression of my coral capillaries where the lesion is. And the second one has a bit more elevation. When looking at the OCT, I often look at 4 different things, this being the most common 3 here, but I look at other entities as well. I look at hyper and hyporeflectivity. I look at location, as Greg had mentioned, and I always compare it with whatever other diagnostic modalities I have, including my photos or dilated exam. Things that hyperreflect have density in them. So we're looking at exudates, we're looking at a choroidal neovascular membrane, or even increased reflectivity, whether you have an artery occlusion here, which is nothing more than a very widened area, I would say, of a Cotwell spot. A Cotwell spot will show, because it's an ischemic area, will show a very small hyperreflected area on the nerve fiber layer. With a BRAO or any kind of artery occlusion, what you will notice in the acute stages is that there will be increased retinal thickening from the OPL to above. And that's actually important to know. So I'm going to show you a case about that. Hyporeflectivity is either fluid or missing tissue. In a JRT or idiopathic macular telangiectasia, we can have an area that's missing here from Mueller cell degeneration. And here we have fluid in association with a patient who had a CRVO and a macular edema. Looking at layers on hand are really important. I'm not sure if anyone would actually guess this one. This was actually very unique. First, identifying what specific layer is it really at. And I'll explain, I have the sedimentation here as an important entity. And two, does anyone know what is this pathognomonic for? Anybody out there want to guess? This one is not easy either. But hey, I put the dome shape and they got that one right away. So I figure might as well put this one. Any takers out there, Joe?
Nope.
This was
Give
not
them a second or two to weigh in. It takes a little time for it to kind of come through. It's a slight delay. So, are they supposed to be looking at the vitreous?
yes. So these little areas here.
Yep. And then above that, maybe for the audience.
So this is just abnormal reflectivity. This would be, but these specific ones like that sticking up like that, it's more pathognomonic.
Mm-hmm.
The two things that came through are vitreous cells and asteroid hyalosis.
Both great differentials, and I will show you both of those. But this one is amyloid. So what ends up happening is because the density of the protein is so heavy, they will come distributed, not too much you'll see it on the vitreous, but you'll see them literally sticking out in a very specific needle-shaped deposit or right above the superficial retina. And the other two were excellent differentials. For the vitritis or cells in there, you will have a distribution like having in a snow globe. So the way I describe it is if you shake that snow globe, it shakes all in the superior aspect of the vitreous. As they deposit, they may deposit here. It's a very circular, small area, but oftentimes you'll see it within the vitreous. In the other one, which we're looking at, the asteroid, here, what ends up happening, it's very specific for it, because of the higher reflectivity of the calcium deposits here, what it will show is instead of sedimenting right on the superficial retina, you'll see it right below, which doesn't make sense why you would have something within the vitreous showing up in the choroid. But what it's doing, due to the high reflectivity and how the instrument obtains its image, it gives you a mirror image of what is seen above, and it will reflect it on the bottom. And that's very common for asteroid halitosis. Then not only you'll see it on the vitreous, but you will see it right here as if it was coming from the choroid as well. And that's because of the mirror image. Now, this one wasn't the greatest photo, but every case that I put on my real cases, so I don't obtain it from the website. So unfortunately, I was trying to show you a little bit of these deposits here and here. And these become really important when evaluating a patient with a PVD. If you see any kind of deposits and reflectivity on the vitreous itself, the likelihood that there is, and that was a patient there, a retinal tear, it's very, very high. Those are likely distributions of red blood cells, and they will show a small hyperreflected specks oftentimes in my OCT. So all my PVD patients, I think it really helps OCT to look at a staging of a PVD, evaluating any other entities, and looking at the vitreous at hand. Do both of you guys get OCTs on your PVDs? Joe, Greg?
It's kind of a standard that if a patient comes in with a PVD complaint, recent flashes or floaters, that during the process, they get dilated, they get an OCT, they get a wide field.
Perfect.
So
You guys
yes.
do peripheral sweeps on your patients too when you get your wide fields?
Well, I don't know what you mean by peripheral sweep, so help me out.
So instead of getting just a standard optos, I have them look up, down, left, and right. Those are what we call sweeps.
Yeah. So it automatically does superior, but we can have them look left and right. So the answer is yes. So
Okay. I found that to be also very valuable because I think optos can miss some images, especially when you're looking for retinal tears or break. Having patients look up, down, and to both sides, getting that full, it almost covers the whole entire area. Looking at this
and
patient, yeah,
I have two cameras in the practice, and I have the Optos. So typically, what my staff will do is they'll use the Aiden, which is an eye care, not claiming any superiority out here,
yeah,
and it does give a little bit clearer image, and it does kind of a 360 type of image. So they usually do the Aiden for me, and then do an OCT.
to get the both.
Yep.
Question here, when you're looking at this massive hemorrhage and macula, it becomes a little tough because you really can't follow the vessels, in particular in that central area. Is this pre or subretinal? But I thought beautifully the OCT depicted this nice pre-retinal hemorrhage. And in looking at a massive hemorrhage, as I mentioned before, a subhyaloid hemorrhage is not as much of an urgency, and these usually will resolve on their own because these are usually secondary to someone who I had a patient who was constipated for like 3 weeks or so post-pregnancy, post-labor and delivery. So these are common and resolved. They get scary, but they resolve on their own. I've had a patient who did get a YAG laser right through the ILM and the subhyaloid area in order to allow for the hemorrhage to drain, but oftentimes becomes a very hot mess because it becomes a very large vitreous hemorrhage, but it does resolve over time. Looking at a subretinal hemorrhage, and again, here's an example of the other one with those peak-like elevations that I told you. That one is far more of an urgency. But this one you can definitely see that is subretinal because you can see all the vessels leading over it. Poll number 3, Greg.
Hey, I'll get it launched here in a second. It is open.
Anything you guys want to add while we're
Nothing to chat. You're all caught up.
They're either quiet or tired because I can understand 9:30 my time. I'm usually looking at the inside of my eyelids. I'm getting older. I get up at 5.
So this is actually polling question number 4 when it was sent to me. So I'm going to pause the other one.
Oh, I'm sorry. To send us 4?
Oh.
Okay.
Yeah, this one's 4. So I'm going to pause that one, audience. Here we go. I'm going to open up this one.
So a tangential pull, pulling across the superficial surface of the retina, described as a hyperreflected area of irregularity. Is that an epiretinal membrane, a PVD, vitreomacular traction, or a choroidal neovascular membrane?
Anything in the chat box there, Joe? Anything rolled in? I know you just looked.
Nothing.
Okay. So polls are rolling in here nicely. Looks like we've got the trend, which is usually doesn't change too much by this point. So let's see here. A little display. We have 60% of the audience going with epiretinal membrane, 11% going PVD, 22%, that's your second one. So that's vitreomacular traction and choroidal neovascular membrane at 8. So your top two are A and C at 60 and 22%.
Which is what I expected, and it is an epiretinal membrane, but VMT is definitely a differential at hand. So we're going to talk about these variations of these tractions. Here's an example of a vitreomacular traction, which is more of an anterior-posterior pulling up from the subhyaloid onto the retina. Epiretinal membrane runs tangentially, as you can see here. So imagine kind of someone holding a rope from one side and the other and pulling on both sides. And then you have further traction from fibrosis that can lead to tractional retinal detachment. So a tale of the two vitreoretinal interfaces. This patient comes in and is complaining of some metamorphopsia for about a month, 20/50 best corrected. Would you call this VMT, epiretinal membrane, or perhaps both? Makes it a little bit tough to tell, but from here, you can see the radial-like appearance across. These jaggedy edges are coming across with an epiretinal membrane, but the patient also has vitreomacular traction. So I've seen it commonly associated in the same patient, both tractional areas. There's definitely fluid coming along with a small little area pulling downward. And patient was asked by my surgeon, what are we, so I had seen a patient initially. I gave it to my surgeon, thinking my surgeon was going to do what she does best, surgery. But she stated, you know what, before I get involved into the surgical case, this won't progress tremendously. Let's wait a month, see how the patient is doing. So we decided to wait a month. Within a month, complete resolution. So it's pretty impressive how some of these cases can resolve completely on their own. The minute that vitreomacular traction detached, the epiretinal membrane kind of glided itself forward and the patient was back to 20/25. Other side of the coin, 76-year-old with VMA or vitreomacular traction, would you call it one or the other? It doesn't make that much of a difference. They're 20/20. We're observing this patient. Seems to be getting a little bit worse, but oftentimes these can detach on their own and the whole entire retina resolves, much like it just happened in the other case. So we continue to watch for another 3 months. Patient decides to not follow up at 3 months, follows up at 6 months. And at 6 months, you have a complete open area here. Now, even though there's still attachment on the superior aspect, it's full thickness. And this needs surgery. And now they're 2100. So patient got surgery and doing fantastic thereafter.
So I just did some investigative work. So I know both of you are in Florida, but that's coming from Joe. I just looked where that thunder came from. So
I was wondering, I was like, what the hell? I thought it was here. And then I was like, I'm just going to ignore that. I got scared.
So knowing where you live, Diane, and knowing where Joe lives, I pulled up the radar, and that definitely came from Sarasota. So
Good.
All right, Joe. So hopefully you'll still be on for a little while. We only got about like 15 to 20 minutes. Patient did very well.
There's Matt. I hear thunder coming again. There's Mal.
67-year-old Hispanic female noticed vision loss 2 days ago, 20/50. Joe, Greg, would you say this is a full thickness hole? What do you think? You're 20/50, by the way.
Full thickness.
yeah, I mean, if it's not full thickness, by definition, I can still see a little bit of holding on down there. It will be within the next day or two.
So that's exactly what I thought. And I'm telling you, sometimes you just never know how these things are going to go. So I got this patient at my cataract surgery practice. So I referred directly to my retina practice, thinking again, my surgeon is going to do surgery. She's like, you know what? There's a little fluid. It just happened. Why don't we give her some NSAIDs and pred? So I don't know if you guys have seen this, but I know my surgeons definitely do it. When there's quite a bit of fluid, they will give them an NSAID and pred, especially if the patient is not too adamant in going under surgery. Because as that fluid kind of sucks in and resolve, this can actually close off and comes back in a month, closed off to 2025. So I would have said
You
exactly.
say their recent cataract surgery?
No. She just
Did you
came
say-
to my cataract surgery clinic. She
Okay,
didn't
all
have
right,
cataract
okay.
surgery recently.
Okay.
No.
Okay.
She just didn't come to my retina clinic originally. She came to the other clinic. But interesting enough, 2025. Now this, and I'm showing you case after case where I would have sworn I shouldn't become a betting woman because I would have thought the opposite would have happened. Just to give you the odds are 50-50, no matter what. So a VMT, if it pulls off, 50% chance of becoming a full thickness macular hole, 50% chance of resolving, as you saw some of these cases. When you're looking at it, you really sometimes can't tell which way it's going to go. Both of us had agreed that that other one was going to get worse. It got better. The original one with the epiretinal membrane, I certainly thought was going to get worse. It got better. And the little tiny traction got worse. Here's a much more interesting example because what do you notice on this patient that there's no longer there? They got what? Right here, this little area, got a nice little PVD. They no longer have technically, quote unquote, traction. And likely they had original traction pulling, which was going to cause this defect. And now hopefully this resolved. Needless to say, you got to pay attention to this area because you do have an epiretinal membrane here. 2025, I was following 2 months. They're doing great. They're 2025. And if anything, I'm not sure, maybe it actually got better because it resolved once this pulling came along. Comes back. 3 months later, now they're 2050, full thickness hole, small. Why? One would question, how can that have happened with the PVD? There's a posterior vitreous attachment. There's no longer anterior posterior traction. But this is exactly why your surgeons will remove the ILM to prevent any glial cells, which are really going to be the epiretinal membrane, to develop in order to make sure the hole closes and doesn't reopen. There was still tractional forces, which was the epiretinal membrane. In that small area, that tractional force was enough to open up that hole again. So it's really interesting. Now they ended up getting surgery. But full thickness holes can develop within weeks to months, and they do go through the progressions of stages 1 through 4. Macular holes almost always or commonly are diagnosed by the patient because they will get that abrupt vision loss. With that stated, looking at the other eye and the OCT become that much more important, especially if someone already had a full thickness hole and they're really worried about developing in the other eye. And if they had a bad outcome in the original, maybe they're a monocular patient. Things that you need to look for are, is there any traction, whether it be VMT, PVD, which usually signifies a very low likelihood of a macular hole development, unless there's an epiretinal membrane. And if there is traction, is it pulling? Is it progressing? Is the outer retina intact? Those are the things you really want to look with the OCT to determine the chances that this will develop a full thickness macular hole. Greg, I think you talked about this. The OCT is the atlas of anatomy, another hole, but this doesn't make sense. How the heck are they 2060? You got a large full thickness hole and you're looking at it. They're not cheating. How are they 2060? You brought this up. Look at every scan. In reality, it's an eccentric hole. It's inferior. The area going through that is actually just fluid, which is why they're 2060. And that patient wasn't treated. Diagnosed with a scar in 20 and has 2020. Really what we're looking at is not necessarily a scar, and that's going to become important to identify why. You have a cleft, which is an opening space. Remember that hyperreflectivity can signify fluid, but it's also missing tissue. In this cleft, this is pathognomonic for the diagnosis of this torpedo-like appearance. So I've given you the diagnosis already. And the excavation inferior to that is a secondary disease, which is a focal choroidal excavation. So it's not important that you identified a torpedo maculopathy. You could have called it just a macular defect. That doesn't matter. But just like Greg alluded to, you have missing and disrupted area within the RP. And even though it isn't common, they can develop choroidal neovascular membranes, which this patient did 2 years later and needed treatment when they came in with metamorphopsia. So even scars, think about geographic atrophy. You have centralized geographic atrophy, yet they can still develop choroidal neovascular membranes adjacent to the atrophic area due to the ischemia, due to the metabolic changes. So you got to be that much more careful. Anything you want to add, Greg or Joe?
The
Oh, no,
only
there's
thing
just-
I want to add, go ahead, Joe, you go first.
No, there's just a question that came in. Do you ever recommend vitreous supplements with VMT, in supplements with VMT patients?
Do I have a recommendation in what?
Supplements.
Supplements, no, because it isn't, as Greg had mentioned, a metabolic disease and an abnormality. It's a dynamic abnormality. So given the fact that it's a dynamic between the posterior hyaloid fighting against the macular area at the ILM, there isn't, unfortunately, any supplements that can be given.
And my comment was going to be, this kind of justifies why you can follow these patients, these great cases that Diana is presenting. You know, see them, explain to the patient that, you know, you have a macular condition, you know, I feel comfortable following these. You can refer out if you want, but I've worked with retina, and I know they're just going to say, well, let's follow it back in 2 months because there's no surgery. My point of the is that, people are like, oh, I can only do so many OCTs in a year, blah 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 blah. Maybe in glaucoma, one or two is about all you could do. But when it comes to retina, it's based on your retina decision making, how you're going to follow the patient. So following these patients 6 to 8 weeks just to see what's happening dynamically, you can get tricked. You think it's going to tear open, it goes better. You thought it was going to get better, it tore open. So the key is that you just follow them closely, 6 to 8 weeks, maybe 3 months, and you bill for it. You're not being flagged. You have it all you have it all documented, and there's plenty of cases out there that Diana is showing you that justifies following these patients because you never know which way they're going to go.
And at the end, too, just to add to that, if it did open, and it opened on your watch, it could have opened on anyone's watch. At the end of the day, that's a dynamic of the disease. The treatment was not going to be initiated until there was a full thickness hole there. And now you justified it, you found it, and you had at least data to prove that it had progressed over the time. So great point. Here's a patient that was sent to me for an artery occlusion. So again, looking at the whole entire clinical picture is important. First and foremost, she's 37. Not to say that young patients do not get artery occlusion, especially with disorders like inflammatories, like antiphospholipid syndromes, or some of these homocystinuria and just unusual disorders, or blood dyscrasias, but it is less likely in a younger patient. Number two, if you thought it was an artery occlusion because they were worried about all this whitening across here, they're 20/20. And if it's encompassing into the macula with whitening, there is no way this patient would have been 20/20. But what was really happening here is that this was normal. Remember the young patient I told you, the retina looked dystrophic, they should be shiny. This is a normal shiny area of the retina. This is the wedge defect that the patient has. And what the patient has is glaucoma and not an artery occlusion. But what we're zoning in is not this area, it's the wedge underneath that really very nicely is delineated underneath. And I am certainly not a glaucoma expert, and nor am I going to give you all the clinical pros about glaucoma, although I do see and treat quite a bit of it, particularly at my cataract and refractive surgery. But I wanted to give you some examples of some abnormalities that we might see. Here on the other side of the coin, this is a patient with a potential defect, although it kind of looks a little widespread. And in looking at the GCC, unless a patient has pretty severe end stage, this is not going to be your early glaucoma staging. Usually you have these little step-like defects, what they call the squeegee-like defects. The patient was believed to have glaucoma, and there's definitely thinning of the nerve fiber layer. The defect here does not look glaucomatous per se, but it does have an impact on this inferior GCC defect on a patient who did have an artery occlusion and complete thinning of the retina. But remember that if the macula is going to be affected, the GCC is also going to be affected. Couple of clinical pros is the only thing I'm going to share with regards to glaucoma is how to read a map. I don't get bombarded with the numbers only, because I think if you look at the numbers only, you will go down a rabbit hole. And there was oftentimes things that are called red disease and green disease. I think looking at my maps, the same way you look at macular maps, become really, really important. And because in a map, you can clearly see, is my wing, I like to call these the wings, are they chipped? Is it a robust area? Yes, I think it's important to be able to look at the symmetry between them, look at your disc area. Larger discs will have larger cups sometimes. Looking at the ratio, I don't always correlate the ratio of the CD with my patients. I don't see that it correlates as well as it should, but looking at my overall wings and associated defects become important. Also, this data is gathered inside here. Oftentimes you may see defects coming further out. They're going to come in and they haven't been flagged yet. Or you will see defect of, say, somebody who's got a peripapillary atrophy or high myope. There are not really defects. That's why I think the maps become really important to evaluate. Here's this step-like squidgy defect that I mentioned that is often common with glaucoma. This is not as often neurological, and I'm sure Joe has great neurological cases that he can show you. But knowing the fact that we have only 5 minutes left, I do want to address the last case that we talked about. and one aspect of papilledema. When it comes to papilledema, I want to say, and this came up in the earlier case, the most important thing to evaluate is the nerve fiber layer thickness. I know you're going to hear from lots of lectures, and there's nothing against anybody's lecture about a lazy V in the Bowman's membrane and how it inundates downward with drusen and it may be elevated. But the real key thing when you're looking at nerve swelling is the nerve fiber layer swollen? In optic nerve head drusen, I've had cases with swollen nerve fiber layer or the elevation of, I shouldn't say swollen, I apologize, I should say elevation of my nerve fiber layer. But oftentimes what ends up happening is optic nerve head drusen, both will have a elevated neuroretinal rim. That's why they look elevated to you. The rim looks elevated. But true papilledema would often have an increase of the nerve fiber layer, and drusen doesn't usually. This is not to say it doesn't happen vice versa, but that's one of the more important aspects that I look at is my actual nerve fiber layer. Anything you want to add? Because I know you can add hundreds of things, Joe, in regards to, especially with your expertise in neurology, but when it comes to nerve fiber layer evaluation, before we get to the last case.
The reality is OCT is only okay in differentiating early disc edema.
Agreed.
Frankly, I'm not going to go that recumbent V or lazy V or put anybody's health at risk on such what I think are dubious findings. There are a few things that help, and there are a few things that I've seen that you would say would be seen in a normal person, and it was disc edema. So it's only, it's really for me only okay.
Agree, 100%. And like I said, the only thing I really look at the most, if I'm just having it, it's really the nerve fiber layer, but 100% agree. Thank you, Joe, for sharing.
And,
So
a lot of the things that we know about, if you look at something at an image, you can talk yourself into these findings.
That's a very good point. That's so true. So coming back to the beginning case that we talked about, I think this one kind of really ties how important OCT was, particularly in this patient. Looking at the dilated exam, you really would not have seen this finding. Yes, they had glaucoma, take that out of the equation. Yes, they were treated for glaucoma, take that out of the equation. But these small hyper-reflected areas above the OPL, very, very subtle. Patient was 20/20, remember, but they kept telling, they were adamant there was something wrong with my eye. That is think about it as a small artery occlusion. It's what we call as PAM. In these acute middle maculopathies, which are so-called questionable paracentral. So paracentral meaning they're not affecting the fovea, it's right next to the fovea. Acute, patient had some sort of visual disturbance 2 weeks ago, so it's acute. Middle, because it affects the area above the OPL. Just like Greg mentioned, above the OPL is your ischemia, is your diabetes, it's your artery occlusions, it's your MAC-TELs. Below the OPL and into the outer retina, that's your RP, that's your choroidal neovascular membranes, that's your plaquenil patients. But here you have these small hyperreflected areas, which I think you really can see fairly well on the ENFAS. This is a small artery occlusion. It's exactly what it is. This patient was sent to the hospital, stat, as we need to do for a patient who has an artery occlusion. MRI, MRAs, or diffuse weighted image needs to be done, including a carotid Doppler and an echo, and the blood workups for evaluation of GCA and so on. But the important thing for this particular patient of mine, MRIs were normal, or relatively normal, I should say. There was a couple of findings, but the key thing about this is this patient had an undiagnosed PFO, and their perforated small hole that they had congenitally was likely leading to, at least that's what the doctors had believed, 2 blood clots that led to this PAM. And now the patient has been put with pre-stroke risk factors. But if we didn't identify this PAM, we would not have done any of the evaluation. And thankfully, the patient did not have a stroke. But it was a very subtle area identified through the OCT. And I'm going to leave you with these last 3. We are done here. I had a great pituitary one I was going to show you, but we're not going. Here are my little famous OCTs. Here's my ghostly VMT. We got my koala bear. I kind of found ones and see what the picture looked like. I thought I could do a little book out of this. Here's my Crown Royale. Don't judge. None of these are perfect. Here's my Willie Coyote anvil-like shape. Here's my ice cream cone. I thought that was pretty good. Oh, this one's not mine. I got to give credit to a doctor from Bascom Palmer, but this is a gator growl. And there's my Florida's OCT weather forecast. And I thank you guys very much. I know it's been a long night. I'm happy to answer any questions. Both Joe and Greg have my email. And I want you guys to have a wonderful night. And I am not pressing turn off or anything like that. And with some OCT love. We're good, exactly on time,
All right.
9:49 on the dot.
All right, so I'm going to stop your sharing. I'm going to bring up my slides here and remind the audience in about a minute, you're going to see this little red dot pop up. Joe, are there any questions?
Nope.
For Diana? All right.
There are
So there's going to be a red dot here at less than a minute. It's going to be right here, and you can start that survey. And if there's no questions, Diana, I want to thank you for being here tonight. Obviously, your command of retina is stellar. Never let us down. The energy that you bring, the education that you bring was fantastic. Joe, any questions or comments rolling in, and then you can make some comments regarding.
Well, the comments rolling in, everybody's thanking Diana, giving her virtual round of applause.
Thank you, guys.
We actually, Greg, you and I just got to thank you for coming to Michigan and for our live series. And just to let you know, we're going to be coming back again next year, November 7th and 8th. It looks like.
And the little red dot has appeared, so you guys can start the survey. If there's just virtual thank yous and comments, well, thanks everyone for trusting Optometric Education Consultants with your education. Diana, thank you for doing a great job of decoding the OCT from obscure to obvious. It was a great synchronous virtual course tonight. Thank you for doing it.